The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC with The Genuine Article, and I'm here talking to two physicians from Spain, Dr. Alberto Busas Mosquera and Dr. Jesus Petiero. And these physicians who work at Corona University Hospital in Spain have really won a marvelous honor. They've been selected by the Lancet readers as having written the paper of the year. And of course, it's been published in JACC, and it has to do with the important question of the role of exercise echocardiography in patients in whom the electrocardiogram and chest pain findings are negative. So tell me, Alberto, a little bit about your study.
Well, current practice guidelines recommend exercise electrocardiography as the preferred initial non-invasive test in patients with interpretable electrocardiograms and normal and suspected coronary artery disease. Exercise echo is just an add-on to exercise electrocardiography, and it is well known that exercise-induced wall motion abnormalities appear earlier in the ischemic cascade, and thus exercise echo has higher sensitivity. So our aim was to assess the prognostic value of exercise echo in patients with normal exercise electrocardiographic findings.
Yeah, so Jesus, I think most people think that if a stress test is performed and there's no pain and the ECG is normal, then that's a very low-risk patient. But you wanted to see if, in fact, the exercise echo could change that. How did you go about that?
Yes, to do this, we perform exercise echo to a series of 4,000 patients with normal exercise, with normal resting ECG, and normal exercise ECG results and absence of symptoms during exercise. And we do this using peak treadmill exercise echocardiography. That is a different approach to the commonly performed post-exercise treadmill approach. So we acquire images on treadmill while the patient is running or walking instead of at post-exercise, because we have seen higher sensitivity and higher prognostic value with this method.
Yeah, but isn't that difficult to get an echocardiogram while the patient is moving and huffing and puffing?
Well, actually, it is feasible. I guess what current guidelines say, it is feasible and it is more sensitive and more accurate than the post-exercise approach.
Well, I congratulate you on being able to do that. And what did you find, Jesus?
Well, what we found in this population is that those patients who had the ischemia during exercise, which I mean at peak exercise, the events in terms of overall mortality and major cardiac events were almost double in patients with ischemia versus those who had no ischemia during the test.
Really very important. Now, as I recall, you looked for wall motion score as well as individual wall motion abnormality.
Exactly. The increase in wall motion score index from rest to peak exercise was an independent predictor of mortality and major cardiac events, and also provided incremental information for predicting both endpoints over clinical, resting echocardiographic, and treadmill exercise data.
Well, it's really very powerful information that, in fact, even in the absence of chest pain or electrocardiographic abnormalities, if the echo is abnormal, that patient is at double the risk. Mm-hmm. What should we do with that information? Are you now taking those patients to angiography, or are you giving them medical prophylactic therapy?
Well, I think the most important thing is to identify these patients, whether they should go to coronary revascularization or receive medical treatment alone depends on the stance on the stance of the ischemia. But I think it is important to identify them and to treat them.
Well, this is very important information, and it establishes really a prominent role for exercise echocardiography a good patient population, 4,000 patients, studied well. Congratulations. I think you clearly merited the award that the Lancet bestowed upon you. For the Genuine article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.